Shall I go? Any doubts you have in bronchial asthma or ARDS?
I think the pneumonia, it's lung filled with the fluid.
Lung filled with fluid. Do you do?
Any infection.
Very good, infection. That's all. Khalas. Objective is we have to see pneumonia. In pneumonia, two types are there. One is bronchopneumonia and there is a lobar pneumonia. We will see then lung abscess and bronchiactasis. This bronchiactasis, it is one of the disease comes under the chronic airway obstruction, chronic obstructive pulmonary disease. Okay, we have seen in our previous slides, previous lectures, chronic obstructive pulmonary disease such as bronchial asthma 1, bronchiectasis 2, 3 is chronic bronchitis, 4th is emphysema, last one is small airway disease. These are all the 5 diseases comes under the classification of chronic obstructive pulmonary disease. Why I have kept you here? Because in your timetable this bronchiectasis they have kept here. So that's why I am teaching you here. Now we will go for pneumonia. Pneumonia can be very broadly defined as any infection in the lung. Bronchopneumonia, lobar pneumonia. Bronchopneumonia, this bronchopneumonia you can see patchy. Here and there will be patchy areas. Whereas lobar, entire lobe is affected. Yes, entire lobe, either lower lobe, upper lobe or middle lobe. Or else the segments, we have 9 segments. Either one of the segment completely, 3 segments. Yes, one complete segment will get affected. That's lobar. Bronchopneumonia implies patchy distribution of inflammation that generally involves more than one lobe. Sometimes one lobe or more than one lobe. That will be patchy. That's very important, patchy. This pattern results from an initial infection of the bronchi, bronchioles with extension into the adjacent alveoli. Okay. Next is the lobar pneumonia. Lobar pneumonia is a contiguous air spaces of part or all of the lobe or homogeneous filled with an exudate as a lobar or segmental consultation. One lobe completely or one segment completely, that is lobar. Broncho is only patchy. Clinical features, abrupt, sudden onset. Patient will have a chills, pleuritic chest pain, mucopurulent cough, then patient will have hemoptysis. And what is hemoptysis? Blood mixed with the sputum. When you I said mucopurulent cough is there due to? Yeah, exactly. We will see the pathogenesis now. Pathogenesis is defense mechanism called upon mechanical, cellular. How can these defenses can overcome? Highly virulent organism, massive inoculation, a compromised immune system, and then replication and spread establishing tissue. These are all the various factors. We will go for step 1, entry. As you know very well, pneumonia is caused by infection, any infection. For example, bacterial infection, keep it. Any infection which enters inside, so there is a mechanical barrier for everything. We inhale, yes, we have a nasal hair, inside we have trachea, cilia is there, in bronchi also we have, if there is anything, there is a cough reflex, we will immediately relieve it out. There is a defense mechanism is there, mechanical and cellular level, it protects, yes. Now, this infection, how can this infection overcome? It overcome by highly virulent. If it is very highly virulent, it will overcome. It can able to cross the barrier, mechanical and cellular, go to the lung, trachea and the lung, it causes infection over there. Another is a massive inoculation, heavy inoculation. You are sitting in a pool of an AIDS patient or else tuberculosis patient or else an infectious patient. Yes, if you are working in an where there is an infectious area, an endemic area, Somalia, like those areas, very highly infectious, right? If you are working over there, you will be infected. It's a massive inoculation. Then a patient has compromised immune system with this mutation of a MYDD8 causes a compromised immune system. Khalas. Then what happens? This infection, it replicate and it spread and it will be totally, it will be established in the tissue. Now, this infection, it causes loss or suppression of cough reflex. Suppose a patient X is having an suppression of the cough, he is unable to cough, suppression, then the infection it enters inside. Injury to the mucociliary apparatus. A person who is chronic smoker, what happens? His mucociliary apparatus is affected. And this infection is enter inside. Interference with the phagocytic action. A patient who is chronic smoking, tobacco user, alcohol. This infection, the function of the macrophages is to engulf. It is affected. When it is affected, what happens? This infection, it enters inside. Pulmonary patient having a pulmonary edema, there is lots of chance of infection. Then accumulation of secretions such as cystic fibrosis and chronic obstructive pulmonary disease. In patient with a chronic obstructive pulmonary disease, this is a genetic condition, cystic fibrosis genetic condition. In this condition, there is lots of chance of infection to go into the lung and get affected. This is the how the infection is crossing the barrier and getting affected. This is the infections. Streptococcal pneumonia most common. Then Haemophilus, Staphylococcus aureus, E. coli. This is a community acquired atypical. This is a typical atypical Mycoplasma, Chlamydia. This is nosocomial Klebsiella, aspiration pneumonia, anaerobic fusiform, Staphylococcus aureus, Haemophilus influenza. Chronic pneumonia such as nocardia, actinomycosis. Necrotizing pneumonia causes anaerobic bacteria and the Staphylococcus aureus. The pneumonia with immunocompromise. Patient having an AIDS disease such as weak immune response, cytomegalovirus, Pneumocystis carinii, Mycobacterium, avium, invasive this is a parasites, aspergillosis and candidiasis. These are all the various infections. Apart from that, there are almost another 100 infections are there, but this I have kept it very common. Now, I said you 4 stages. One is stage of congestion. I was going on discussing you stage of congestion, red hepatization, grey hepatization, and resolution. These are the 4 stages takes place in lobar pneumonia. Okay. Stage of congestion nothing but boggy engorged alveolar vessels due to infection. After the infection in the alveoli, there will be an alveolar edema, followed by the vessels which are near to the alveoli. It will release the neutrophils RBCs inside the alveoli. It become, once it is releasing the RBC and the neutrophils, because of the huge collection of RBC red in color, it will become red. That's why red hepatization. Okay. Now after that, once it is released in the alveoli, no, yes, here entire lobe. Now the alveoli, you are full of collection of neutrophils and the RBCs. After sometimes the RBC it get disintegrate, it breaks. Okay, then it will become grey in color. So grey hepatization. The last one is it gets resolution. It try to heal. Coagulation? Yes, not coagulation. It try to coalesce. It try to heal. Because what happens if this one continues, then patient will get collapse. So it should get healed. That healing process is resolution. That is return to normal or near normal stage. Red hepatization lobe is confluently filled with intraalveolar neutrophils, RBCs, resulting in liver-like state. Okay, because the liver is dark red in color. Lung is brown in color. Because of the RBCs, it is resembling like a liver. That's why you call it as red hepatization. And then grey hepatization is the neutrophils as well as the RBCs and other inflammatory cells. What happens? There will be destruction. So that's why it calls a grey. Yes, a grey in color. I don't have a red color, classic one. This is a very classical picture of grey color. This is the upper lobe, lower lobe showing grey in color. Lobar pneumonia with grey hepatization. The lower lobe is uniformly consolidated.
Grey like whitish?
Grey, not whitish, before whitish in color, grey color. Okay.
No, this one.
Yeah, this one.
It shows like white.
No, this color, this color, grey color. This color. This is a microscopic, just now I showed you. We have 4 stages: stage of congestion, stage of red, grey, and resolution. This is the stage of second stage of red hepatization. This is alveoli, full of neutrophils and RBCs. Neutrophils, RBCs. It is red in color. This is the edema. I said you edema. Okay, edema. This last stage is the fibrosis. Resolution takes place. Now, bronchopneumonia will go for. Till now we have studied pneumonia 2 types. One is bronchopneumonia, lobar pneumonia, right? Lobar pneumonia, it affects the entire lobe, and there are 4 stages. In bronchopneumonia, there is no stages, it affects only patchy. Tiny foci of consolidation surrounding the bronchioles. This is the bronchioles, so all the bronchioles. There is tiny, this is the one, this is exactly, this is the tiny foci of consolidation. In the bronchi and bronchioles, you will see consolidation, obstruction. Okay, microscopically you will see this is the alveoli, this is the bronchiole. You will see suppurative material.
This obstruction will lead to accumulation of RBCs.
Yes, accumulation it takes place. But in lobar pneumonia there will be 4 stages, whereas in it affects bronchopneumonia, lobar pneumonia, it affects the bronchi and bronchioles only. Okay, in bronchopneumonia it is patchy. It is patchy. Bronchopneumonia is patchy, and then you will see, and both you will see neutrophils only, both neutrophils. Here you are seeing this mucopurulent material. This is the bronchioles. This is alveoli. It's clear?
Yes.
Next we will go for complications such as both bronchopneumonia and lobar pneumonia causes abscess formation, empyema of the gallbladder, organization this is totally, it will be organized. Then it causes, there is an infection over there in the lung, it goes to the brain, causes meningitis, it can go to the bone, arthritis, it can go to the heart, causes infective endocarditis. This one you would have studied in your CVS, right? Next we will go for the smallest chapter, lung abscess. Lung abscess refers to localized, very important, localized area of suppurative necrosis within the pulmonary parenchyma, resulting in the formation of one or more large cavities. Lung abscess, it's the infection in the lung affecting one lobe or the 2 lobes. It's a localized area. That localized area is undergoing infection, necrosis, formed by cavity formation. That's all. Cavity formation. Okay. Yes, destruction of the tissue. Etiology is any infective material, any infection. We have studied till now. In pneumonia, there is a lot of infection. All those infections. Okay. Suppose a patient is having a tooth and a caries tooth. You know caries tooth? No, which tooth is destroyed due to the food particles over there. We will call it as caries tooth. Infection in this caries tooth. Who is doing a surgery work from there? It goes to the lung. Aspiration of the infective material from the caries tooth or the infected sinuses or the tonsils, aspiration of the gastric contents, complication of necrotizing bacterial pneumonia, just now is bacterial pneumonia, a bronchial obstruction, septic embolism, hematogenous spread of bacteria. These are all the things indicate infection from various places going to the lung, affecting the one part of the lung, destruction of the lung, forming a cavity formation. Grossly,
The infection came from outside the body, it's not abscess. Something it's always the same.
it's already it is there.
From
Anywhere.
outside.
It can come from the outside also. It can come from the outside also. It can cause an infection over there. What happens here is it affects. So, yes.
That's the main point of that.
Yes. It causes a localized area of infection, and it causing an localized area. That is very important. Localized area of infection. Till now we studied either in the bronchi or the bronchioles or the alveoli. Till now, but here is one part. Okay, one area. It's undergoing necrosis and cavity formation. Grosses abscess range from diameter from few millimeter to large cavities up to 6 centimeter. Focal suppuration nothing but the neutrophil collection only, we will call it as suppuration. Pus, we will call it as pus, no? That is suppuration.
These cavities only in lungs?
Only in the lung. Suppuration enlarges, it almost inevitably rupture into the airways. Microscopically, focus is surrounded by variable amounts of fibrous scarring, mononuclear inflammatory cells such as lymphocytes, plasma cells and macrophages. These are all the various cells you will see here. Clinical features such as cough with a foul smelling purulent or sanguineous sputum, occasionally hemoptysis, spiking fever, malaise, clubbing of fingers, weight loss and anemia. Complication, patient have pneumothorax or empyema, meningitis or brain abscess. What is it indicating here? Yes, see here. Now patient patient may have a cough. Okay, foul smelling discharge when he coughs, when his sputum is coming out, it will be very bad smell because of the lung abscess. Yes, sometimes blood will come out. Patient will have a fever, clubbing of the fingers, nails. Yes. Then weight loss, anemia. Complications such as patient will have a pneumothorax, air filled in the thorax, or else patient that infection which is okay. Next, the last one is the bronchiectasis. This picture is there in your practical session. Bronchiectasis is defined as a permanent dilatation of the bronchi and the bronchioles, inside the bronchioles, caused by destruction of the muscle and the supporting elastic tissue resulting from associated chronic necrotizing infections. Again, bronchiectasis due to the infection, bacterial infection or viral infection affecting the bronchi and the bronchioles. The bronchi and the bronchioles is having elastic lamina, which will affect the elastic lamina. Permanent dilatation of the bronchi and bronchioles caused by destruction of the muscle, bronchial muscle and the elastic tissue. Thereby it causes bronchiectasis.
There is no support, no.
There is, see, if you this is a lumen, okay. If you have a support only, it maintains its normal structure. There is no elastic lamina, it will be loosened.
Yes. So
it will be dilated. It will be dilated. Okay, it will be dilated, but there will be collection of, because of the infection, there will be purulent material in the lumen.
Yes.
That's what it is. Permanent dilatation of the bronchi and bronchioles caused by destruction of the muscle and the elastic tissue resulting from infection. Obstructive causes, mostly I said here associated, resulting from or associated with infection. Sometimes without infection also there are other causes such as a tumor of the lung, squamous cell carcinoma, tumors, malignancy of the lung. That can also cause bronchiectasis. Yes, anything. Foreign body in the lung, or else any concretions or secretions, chronic period of secretions. Then he is in third year.
Yes.
Non-obstructive is, these are the obstructive causes. Non-obstructive is infective causes, like such, just now we read many causes like pneumonia, streptococcal pneumonia, various. In pneumonia we have read some 20 to 40 infections.
Also, damaging the structure.
Yes. In another 10 minutes.
10 minutes?
Yes. In infective causes such as, these are the infections, pneumonia, streptococcal pneumonia, pneumococcal pneumonia, staphylococcal aureus, Klebsiella, all those are all infections. Then tuberculosis, inherited causes such as cystic fibrosis, immunodeficiency, carcinogenesis. These are all the immunodeficiency patient will also have bronchiectasis. We have obstructive causes, infective causes. Okay, due to immune deficiency also we can cause a bronchiectasis.
So the constructive patient not having a treatment will lead to this
bronchiectasis. Now pathogenesis is, this is the normal lumen, bronchial lumen, smooth muscle, yes. Obstruction and chronic persistent infection. For example, a patient has been infected with staphylococcal aureus or streptococcal pneumonia, okay, infection. What happens next? It impairs the clearance of secretion. Once there is an infection in the lung, there will be an secretions, okay. Infection, it is unable to clear the lung. What happens? You usually go and block the bronchi. That's why patient have wheezing, shortness of breath.
yes.
So it impair the clearance of secretions. Next, providing a favorable substrate for superimposed infection. Those purulent material which is there in the bronchi and the bronchioles, it will accumulate more amount of infections.
It will dilate.
Yes. The resultant inflammatory damage to the bronchial wall. This will result in damage to the bronchial wall. Then the accumulating exudate further distend the airways, leading to irreversible dilatation. In the sense, totally it will be dilated. Conversely, a persistent Infection in the bronchi and bronchioles may cause obstructive secretions, inflammation throughout the wall, and it causes bronchiectasis. That's how it goes. You clear now?
Yes, accumulation of the necrosis.
Yes, yes. Infection, it is infection causing purulent material in the bronchi. More, this is causing many more infections to come and join. Yes.
Then accumulation of necrosis will lead to dilation of the
Bronchi. That's all. This is the one. Morphology is mostly it affects the lower lobe of the lung. Okay, lower lobe of the lung, particularly air passages that are vertical. And then it just this is a very important point. Yeah. Most severe in the distal bronchi and bronchioles. Airways are dilated sometimes up to 4 times the normal size. In bronchial asthma it is constricted. In bronchiectasis it is dilated. That's the difference. Chronic cases, fibrosis of the bronchial and the bronchial walls, and you can see peribronchial fibrosis. Peribronchial, this is the bronchi. In the outside the bronchi, you will see fibrosis. This is the one. This is the cut section of the lung, showing this is the bronchi. This is one more bronchi. How much? This is the normal one. You can say. This is how much it is enlarged. Almost 4 times from here to here. Huh?
Actually, more than 4.
More than 4 times. Yeah, more than 4 times. You can see here inside mucopurulent material, pus. Yeah, this is the one. Microscopically, this is the lumen. This is the lumen. No, this is the lumen. Epithelium. This whole thing is the bronchi. You are seeing infective material, suppurative material, pus. Clinical features: patient have a cough with expectoration of mucopurulent, sometimes fetid sputum, in the sense foul smelling, bad odor. The sputum may contain flux of blood. Hemoptysis can occur. Patient will have a decreased oxygen and carbon dioxide level will be increased. Metastatic brain abscess, in the sense from the lung, the infection goes to the brain, it causes abscess over there. Then pulmonary hypertension and car pulmonale, in the sense. Patient with the heart, you know car pulmonale? What happens? Right lung, it supply oxygenated blood to the left heart. If the lung is not functioning properly, it will receive blood from the right heart through the pulmonary vein. Right heart will supply blood to the lung.
I think the problem is the right atrium cannot push the blood.
Very good. It undergoes failure. Yes. Those failures is known as car pulmonale. Our entire chapter is completed.